Hello. Okay. Uh, okay. Today we have. Hello, everybody. Assalamu alaikum. Bismillahirrahmanirrahim. And hope you are fine at home. And today we have a very good topic that is a little bit, very little to see in clinical practice. But sometimes you get a patient, especially if you are working in ICU, you have a patient with encephalitis or meningitis. He is on antibiotic or antiviral like acyclovir. He gets excessive amount of urination. Means initially he was pouring out maybe 1.5 to 2 liters per urine per day, but after third, fourth day of encephalitis, meningitis, some other neurological disorder, he starts passing 4 to 5 liters, more than 3 liters per day, maybe up to 8 to 10 liters of urine. And patient become tachycardic, hypotensive, and you see within 1.5 hours the unit bag is full. So that is most likely a condition that is called diabetes insipidus, meaning excessive amount of urination without concentrating the urine from the kidneys. That means you are pouring out a lot of urine. Patient presents with history of polydipsia and polyuria. Basically, he is excessively thirsty, even he drinks whatever is available and passing urine in liters, maybe 3 to 20 liters per day. So that is the condition we'll discuss today, and hopefully we'll see the what are the causes, what is the pathophysiology, and what is the investigation and treatment of that patient. So we'll see the diabetes insipidus, antidiabetic hormone, is a vasopressin hormone secreted by the posterior pituitary, and polyuria, excessive amount of urination, and patient is excessively thirsty, taking excessive liquid intake. So diabetes insipidus is basically a disorder caused by inadequate secretion of antidiuretic hormone by the pituitary. That is called central diabetes insipidus. Central means your lack of ADH hormone from the pituitary gland, and the pituitary gland itself can be damaged by multiple reasons, multiple etiologies, maybe localized tumor, some infiltration, some uh, hemorrhage within the pituitary gland, or ischemic necrosis. We'll discuss later on. So when pituitary gland is inefficient, it is not producing excessive amount of antidiuretic hormone. This hormone affects on the terminal tubules of the kidneys, and it helps in water reabsorption. So water reabsorption would be lost when you are deficient. Your pituitary is not producing antidiuretic hormone (ADH). Antidiuretic means if you are producing normal amount of ADH, it will conserve the uh, water from the kidney. If you are inadequate, you are having deficiency of this hormone, that can lead to excessive amount of urination, and that is to be differentiated from diabetes mellitus. That means if you have polyuria, polydipsia with polyphagia, and there is a glucose in the urine, that is a diabetes mellitus. But diabetes insipidus, normal glycemic patient having excessive amount of urination due to disorders. Maybe it may be pituitary, that is a central diabetes insipidus, lack of secretion of antidiuretic hormone, or it may be nephrogenic. Antidiuretic hormone is there, but kidneys are not responding to that circulating ADH. That means it is a renal disease. So that is called secondary diabetic insipidus because of the renal failure to respond to circulating ADH. And third is like psychogenic polydipsia. We'll discuss this later on. So diabetic insipidus is polyuria and polydipsia with kidney producing excessive amount of urine, and patient will be thirsty, and you have to find what is the underlying cause and what is the treatment. So just look at the normal physiological phenomena. If you are thirsty, you want to drink water, that is the normal phenomena. And you in summer season, when there is a hot environment, you have insensible losses increase, you can have sweating, and your body requirement is increased because of the hot water. That means in normally, if you don't take too much liquid, you will see your urine become dark. That means your kidneys are trying to conserve the water which is required. If you take excessive amount of water, like in winter season, you take 2 to 3 glass of water, you will see it is not being lost by the hot weather, it is a cold weather, and you will see the urine is diluted. You will go to toilet every 1 or 2 hours because your body does not need large amount of water. So this is the normal physiological water regulatory mechanism. Your pituitary senses you are having, you are euvolemic, hypovolemic, or hypervolemic. Okay, I'll explain. Volume of the plasma volume is a normal, that means euvolemic. Like let's say we discuss thyrotoxicosis or hyperthyroidism or hypothyroidism. Hyperthyroidism, when there is excess thyroxine. Hypothyroidism, when there is a deficiency of thyroid hormone. And a euthyroid is a state when you are normal, you are having a normal thyroid function. So hypovolemic means your body volume is less. Hypervolemic, hyper means the body volume is high. You are water overloaded. And normovolemic means you have a normal body reserve and your plasma volume is normal. So what happens is normally the pituitary gland sends hormone, which is an antidiuretic hormone, to the kidneys that helps to control your water balance. Whether you need want to conserve the water, the ADH will affect and conserve the water from the distal pulmonary tubule. If you are water overloaded, you drink 3 4 glasses of water. What is your ADH will be secreted and it will let the urine kidneys to pass the excessive amount of urine. In diabetes insipidus, because of the pituitary gland does not make enough area. This is we are talking about the central diabetes insipidus. When pituitary gland is inefficient, it is damaged, the ADH is not produced normally, and the kidney then will have capacity to conserve the water. So kidney will not have ADH available, so it will cause passage of large amount of urine. So this is the mechanism of normal thirst mechanism and water conservation. And what happens in central diabetes because when ADH is deficient and kidney are unable to respond to ADH, and they will have a polyuria. Okay, so diabetes insipidus is characterized by intense thirst. Patient will have severe thirst, polydipsia, and the excretion of large amounts of urine, that is polyuria. That means you can have even 3 to 20, even 20 liters of urine in 24 hours. So it is a result of body not responding or not producing ADH or not responding properly to hormone by the kidney. So it is either central diabetes insipidus because of the pituitary damage, ADH is not produced, and it may be nephrogenic. When ADH is there, pituitary is intact, but kidney disease is there because of some kidney disease. The terminal pulmonary tubule does not respond to ADH. So that is called nephrogenic diabetes insipidus, when kidney fail to respond to ADH. Normally, what we do, we take water, and kidneys remove excess fluid from our body when we are having excessive fluid in our body, and conserve fluid when our body is deficient. So the amount of fluid in the body remains balanced. This is a very very important uh, uh, part of the system. That means your ADH and your kidney, they respond according to the body fluid balance. If you are deprived of water, you are dehydrated, your kidney will conserve the water through effect of excessive amount of ADH, that is produced in response to hypovolemia. If you are excess of fluid in your body, your ADH will be suppressed and your kidney will let the urine pass to become a euvolemic state. So intake is governed by the thirst, and excretion is largely controlled by our body response to antidiuretic hormone. So it is a balance between antidiuretic hormone for the posterior pituitary and your kidney responding to that hormone to conserve water. This is another normal function of the kidneys. You can see the healthy kidneys, they are functioning normal. What they do is their function is to maintain electrolyte and fluid balance and acid base balance. So kidney have a different function. Most common we will discuss today is in that is the water balance. So normally you could see the function of the kidney is water balance, fluid electrolyte balance, waste removal of waste, and hormone production, especially the erythropoietin. And one problem arises when there is a unhealthy kidney in renal failure. In other diseases, you will see patient is overloaded. There is a urea creatinine rises, and there is a hyperkalemia because of that there is an imbalance between the kidney function. So change in hormone level, like you can have hypertension, you can have anemia because of lack of erythropoietin production that is produced by the kidneys, and you can have hypocalcemia because of the hydroxylation of uh, cholecalciferol does not take place from the kidney. So hydroxylation of the vitamin D first in the skin, second in the liver, and third in the kidney. That is third hydroxylation. Cholecalciferol, which is activated form of vitamin D, and that helps to reabsorb calcium. And if you are having kidney disease, you can have renal osteodystrophy because of hypocalcemia and deficiency of activated calcium. So this is the normal physiology and hormone and function of the kidneys. If you have an abnormality, that can lead to diseases. And today we'll discuss if the kidney have a chronic kidney disease, there is some hydronephrosis, obstructive uropathy, or some other diseases that can lead to failure of the kidney to respond to ADH, leading to polyuria and diabetes insipidus, which is nephrogenic type. So if you look at the ADH, which is produced by the posterior pituitary. So ADH, also called vasopressin, is made in the hypothalamus, stored in the pituitary gland, posterior part of the pituitary, and released into the bloodstream by tells the kidney to tubules to reabsorb water back into the bloodstream instead of excrete. So this is the normal feedback of the hypothalamus pituitary in response to water, which is governed by the kidney. Whether if you are hypovolemic, you are having lack of water, the kidney will respond and conserve the water. So diabetes insipidus occur when urinary system does not respond to ADH. So first is central diabetes insipidus because of lack of function of the hypothalamus pituitary axis. And second, if you have a kidney disease, that is a renal diabetes insipidus, then urinary system does not respond to ADH and therefore does not properly regulate the glucose control. So if you look at the brain, so if you have centrally, you can see there is a hypothalamus here, and pituitary gland is here. This is the pituitary stalk. This is the anterior pituitary and the posterior. So ADH is released by the posterior pituitary. Okay, so type of diabetes insipidus, as we already discussed, number one, if you have a deficiency of ADH, pituitary or hypothalamic disease, that is central diabetes insipidus. So central diabetes insipidus is usually caused by damage to the pituitary gland or hypothalamus, whether by tumor indication or some illness, as I discussed, with meningitis, encephalitis. The ADH is not released; it is not stored in the pituitary gland, and it is a deficiency of ADH lead to polyuria, polydipsia, and patient will have diabetes insipidus of central type. If you have a in nephrogenic diabetes insipidus, what happens is there is a defect in the kidney tubules because of kidney disease itself and making the kidney unable to respond to ADH. That is renal diabetes or nephrogenic diabetes insipidus. Then ADH is okay, but your kidney are damaged because of diseases and they do not respond to ADH. That is called nephrogenic diabetes insipidus. Gestational diabetes insipidus we see in in pregnancy, we see lot of disorders, metabolic and hormonal balance is disturbed. Sometimes due to gestational diabetes, gestational hypertension, gestational diabetes insipidus is another variation of fluid abnormality which takes place temporarily in during pregnancy because of the placenta destroys the ADH. It produces an enzyme which have a which destroys the ADH in the mother. So gestational diabetes is a temporary phase of polyuria polydipsia during pregnancy because of enzymatic destruction of ADH during pregnancy. But most important is central diabetic insipidus because of ADH deficiency by the pituitary hypothalamic disease. And number two, nephrogenic diabetic insipidus when ADH is okay, but there is a problem with the kidney. Kidney have a disease and unable to respond to ADH. That is nephrogenic diabetic insipidus. So we'll discuss in detail diabetic insipidus, which is a central or neurogenic diabetic insipidus. That means and number two is a nephrogenic diabetic insipidus when kidneys fail to respond to ADH. So central diabetes insipidus or neurogenic means when there is a disease of the hypothalamic pituitary axis, means ADH is not produced. And number two, nephrodiabetic insipidus when ADH is okay, the hypothalamic pituitary axis is okay, but kidney disease itself lead to diabetes insipidus because kidney damage is there and renal tubules that respond to ADH and they do not conserve water and the patient has polyuria. So signs of if what are the symptomatology and how the patient present to you in the central diabetes insipidus. Both cases, patient will have polyuria and polydipsia. It may be a sudden in onset, as I told you, like a patient in ICU or in high dependency unit may have meningitis, encephalitis, and after 4 or 5 days, then it starts improving neurologically. But you see, he is passing excessive amount of urine, maybe 4 or 5 liters per day, and you got worried what is happening. And either it is excessive drips are given, like patient is given IV fluid, you remove, stop the fluid, and in spite of IV fluid stoppage, he is passing liters of urine, and you suspect he may have diabetes insipidus, a central diabetes insipidus because of meningitis or encephalitis. So abrupt onset, or it may be gradual in onset, maybe over weeks and months. The serum electrolytes usually normal, but in severe diabetes insipidus, when there is excessive water loss, the patient can have hypernatremia. Hyper sodium can be very very high. That means if you have a normal 135 to 145, it can be 160, 170 hypernatremia. It has its own neurological effects when you have a diabetes insipidus with hypernatremia. Means the water is lost and your electrolytes are imbalanced. Usually the sodium is normal. What are the causes in central diabetes insipidus? It may be familiar nerve degeneration in the hypothalamic nucleus. It may be neurosurgical, like you had some neurosurgery, transfemoral hypophysectomy, or irradiation, or some craniopharyngioma was surgically removed. That can be a cause of central diabetic insipidus. If we look at the diagrammatic picture of pituitary hypothalamic axis and the distal convoluted tubule, you will see the pituitary in central diabetic insipidus. You look at the pituitary and the hypothalamus, you see that posterior part of the pituitary hypothalamus, there is a disease and there is a cut off this axis. Means ADH not is produced. So in central diabetic insipidus, because of the posterior pituitary disease, your ADH is deficient. And what happens is, it is non-availability of the ADH that leads to your kidneys are unable to conserve because the ADH is lost, and kidneys are whatever being filtered through the kidneys is poured out. The patient will have a lot of urine, maybe like polyuria, liters of urine per day because of central loss of ADH. So that is the primary problem in the central diabetic insipidus when you have a loss of ADH because of the pituitary disease. Okay, so if we look at the what are the causes, as I told you, it can be a neurological causes, it can be localized disease of the pituitary gland or hypothalamus because of adenoma, the hemorrhage within the gland. It may be head trauma, ischemic encephalopathy, or hypoxemia. Hypoxia can be a cause of central diabetes mellitus. Cardiopulmonary arrest, patient having cardiopulmonary arrest, you do CPR, but may take 20 to 30 minutes, the patient become hypoxic brain injury that can lead to central diabetes mellitus. Shock state and Sheehan's, when post on pituitary necrosis, if you have a that postpartum excessive hemorrhage, and that can lead to pituitary damage, that is called Sheehan syndrome. That is one of the cause of diabetes mellitus. But with ADH deficiency, you will have prolactin deficiency and other pituitary hormone deficiency, and that is there will be history of postpartum hemorrhage, and there is a failure of lactation. Patient may have diabetes mellitus with polyuria and other hormone disturbance. Number three, neoplasia. Neoplasia may be primary craniopharyngioma, paninoma, or there may be a localized cyst. Metastatic may be some metastatic spread from breast or lung cancer that can lead to a deposit in the pituitary or hypothalamic area, leading to pituitary damage and loss of ADH. Miscellaneous causes include infiltrative disease like histiocytosis, sarcoidosis, cerebral aneurysm localized. Cerebral aneurysm can have a pressure effect and damage to the kidney. Meningitis, I discussed, is meningitis encephalitis can be a cause of loss of ADH from the pituitary or hypothalamic area. And anorexia nervosa is the one of the cause. Okay, and now nephrogenic diabetes mellitus. So first we discuss the central diabetes mellitus, that is because of the neurohypophyseal damage to the hypothalamus and the pituitary, leading to deficiency ADH, and it is not available to the kidney, disturbance to bile and patient passing out of urine. And causes are localized tumor, localized adenomas, meningitis, encephalitis, central brain diseases. Now we come to the nephrogenic diabetes mellitus. Nephrogenic diabetes mellitus is because of the failure of the kidney respond to ADH. I mean, kidney disease is there, and it is not responding to normally circulating ADH. So nephrogenic means your central part is okay, your pituitary, hypothalamus, ADH secretion is normal, but kidney is damaged, and the ADH which is circulating normally is not effective because kidney damage, your renal tubules are damaged. So that is called nephrogenic diabetes mellitus. So it is because of the decreased water reabsorption in the distal coronary tubule. The kidney are damaged, distal coronary tubules are damaged, and they do not reabsorb the water. So normal plasma AVH level. So you will have the AVH with the present ADH would be normal, but it is a disease of the kidney which leads to polyuria, polydipsia, gradual onset. It is usually gradual onset, and it may be acquired because of familial and congenital factors. We look at the nephrogenic diabetes mellitus. If you look at the hypothalamic pituitary axis, the pituitary posterior part of the pituitary is normally producing ADH. Initially in central diabetes mellitus, here is a cut, means that your pituitary is not secreting ADH, but in nephrogenic, the pituitary uh, hypothalamic area is entirely normal. It is the normal functioning pituitary where the normal release of ADH, and you will see the kidney. Here is the problem. ADH is available, but kidney renal tubules are not responding to that circulating ADH. It is a nephrogenic. It is a renal disease causing diabetes mellitus. So here is a central diabetes mellitus because of ADH deficiency. Here is the nephrogenic diabetes mellitus because of the renal disease itself, and patient will have water loss because kidney are unable to conserve or reabsorb water. So it is a reabsorption of the problem, reabsorption because kidney are damaged, like in renal failure. Okay, so causes of acquired causes of renal tubular damage may be pyelonephritis, maybe analgesic nephropathy, maybe multiple myeloma, in amyloidosis, sarcoidosis, obstructive uropathy. This is the post-obstructive uropathy is very, very important, leading to hydronephrosis and damage to the distal coronary tubules and leading to polyuria because of the renal damage, and that is even hypercalcemia and hypokalemia. Hypokalemia, when potassium is low, that can lead to diuresis, and hypercalcemia that can lead to primary hyperparathyroidism. You can have polyuria because of the hypercalcemia. That can also damage to the renal tubule by nephrocalcinosis, and the kidneys are damaged because of hypercalcemia leading to nephrocalcinosis, and they cause diabetic insipidus of nephrogenic origin. Sickle cell anemia, yes, it can lead to renal necrosis, renal infarcts takes place to small vessels, and sickling effect, and that can lead to nephrogenic diabetes insipidus due to renal damage. Sjogren's syndrome, part of the collagenopathy, that can lead to nephrogenic diabetes insipidus because of the renal damage. Drugs which are very important that can to renal damage leading to nephrogenic diabetes insipidus may be lithium, dimethylcycline, methoxyfluorine, ethanol, and amphotericin. Amphotericin we use in patients with parasitic, fungal infection, when they have like patient with fungal infection. They need IV amphotericin that can lead to renal damage. They are nephrotoxic drugs, and patient with mucormycosis will use amphotericin. Then you have a fungal infiltration of the palate, and it can lead to CNS involvement, and drug of choice is amphotericin. So these are the drugs which can lead to renal damage and leading to nephrogenic type of diabetes insipidus. Okay, then we come to the third variety, that is called primary polydipsia or psychogenic polydipsia. That is a inappropriate thirst caused by reduction in the set of osmolality mechanism. That means patient is either having some schizophrenia, some mania, some depressive, some psychosis, and they start taking excessive amount of water and lead to polyuria. That is called psychogenic or primary polydipsia. So in association with the brain, such as neuropsychoid, tuberculosis, melanoma, or other diseases, psychogenic polydipsia is not associated with that thirst, but patient will have polydipsia and psychosis, and the patient will have obsessive compulsive disorder. Hypergenic polydipsia patients are normally, they are healthy people, but they take lot of water and pass lot of urine because kidney they are overloaded, and your water balance is maintained. If you are taking excessive amount of water, it will be passed to the kidney, and there will be a balance between the intake and output. So primary polydipsia, you will have a hypotonic urine state. That means polyuria, polydipsia. This is seen in psychological disorder like delusion, depression, agitation, hysterical behavior, and water consumption will be irregular from hour to hour and frame to day. And patient have hypothalamic disorder, may have a hypothalamic disorder, but patient may have normal sodium, slightly maybe a dilutional effect because of the, this is called water intoxication. The patient is taking a lot of water and may have dilutional hyponatremia. And rare cases may have lethal hyponatremia. Patient are drinking a lot of water, plain water, and they will have a dilutional hyponatremia that can have a some, if sodium is less than 125, they may be symptomatic. What happens, the brain edema takes place, and sometime below 115, they can have even fits. So seizures can take place in severe hyponatremia. So this is a condition when you have a psychogenic polydipsia patient taking a lot of water, and you can have lethal hyponatremia. And if you do the water deprivation test, you will see the urinary osmolality between 600 to 800 after depriving the water, means that the kidneys are normally responding if you stop taking water. And DDFP will have a less increase in the urine osmolality. That is the test. If you, in patient with you suspect patient is normal, he is having some psychological disorder, he is not having renal or some central brain disease, like pituitary is intact, your ADF level is normal, but patient is excessively taking lot of water and pouring lot of urine. That is called psychogenic or primary polydipsia. And you ask take the patient under observation and go for water deprivation test. You see, if you stop taking water, your kidney will respond normally, and urine which was dilute, it will start concentrating because your intake is low, and you will have urine osmolality increase gradually. That is But in the nephrogenic diabetes insipidus, if your water intake is reduced, or you will have no effect. So in psychogenic polydipsia, simple water deprivation test can be very diagnostic, and the kidney will respond to restriction of water. So we'll next in nephrogenic diabetes, polycystic kidney and medullary cystic kidney can be a cause of. So this is another term used, which is called Wolfram syndrome. Wolfram means dead wall. That is a syndrome characterized by then there is a diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. This is a inherited autosomal recessive trait, incomplete penetrance, and that can lead to a syndrome that is called dead wall, Wolfram syndrome. Did DI means diabetes insipidus, DM means diabetes mellitus, optic atrophy, and deafness. So this is a you will see in type 1 diabetic who are blind, and they have visual impairment and deafness, and they also have deficiency of ADH, leading to diabetes insipidus. So diabetes mellitus with diabetes insipidus. So congenital hypopituitarism, this is another when you have a pituitary failure, you have a central diabetes insipidus, then the patient have a congenital hypopituitarism, means your there will be ectasia or ectopia of the posterior pituitary lobe, may be associated with growth retardation and multiple anterior pituitary hormone deficiencies. The congenital hypopituitarism may be a patient is seen in dwarfism with the pituitary growth hormone deficiency, with the ACTH deficiency, TSH deficiency, multiple hormone deficiency, leading to a congenital hypopituitarism. So, central diabetes insipidus, when ADH deficiency is there, nephrogenic diabetes insipidus, when kidney damage is there, ADH is not affected because kidneys are damaged, and you will have psychogenic polydipsia when patient has psychological psychosis, mania, some other disorders leading to excessive intake water, and we have central diabetes, we have nephrogenic diabetes, and psychogenic polydipsia. So how will you make a diagnosis? What are the tests which are usually done to make a diagnosis or differentiate between these three types of diseases? So high serum, first of all, patients are checked for serum urea, electrolyte, sodium and potassium, calcium, and glucose, urine and serum osmolality. So these 6 tests are mandatory to make a diagnosis of diabetic insipidus, because serum osmolality can be measured by a by 2 into sodium plus potassium plus urea plus glucose. Normally, serum osmolality is 285 to 295. So, if in diabetic insipidus, usually your serum osmolality is more than 300. So, that is the if you have a patient of suspected of having polyuria, polydipsia, suspected of having diabetic insipidus of central in origin, means a deficiency of ADH, may have history of meningitis, encephalitis, some surgery to neurohypophysis, or some history of stroke, some history of post CPR and oxygen damage, and he start passing a lot of urine. So you advise the test to make patient is having diabetes with a central in region. So you will ask for the patient sodium, potassium, calcium to rule out hypercalcemia. You will ask for glucose to rule out diabetes mellitus, and you will check for sodium and potassium, because hypokalemia can lead to polyuria, and sodium because you want to check the hypernatremia, or no, sodium is normal, and you will calculate the serum and urine osmolality. Serum osmolality, you should know what is the equation used, that is 2 into sodium plus potassium, in case sodium potassium multiply by 2, and then you add urea and glucose. The normal serum osmolality is 285 to 295. So low urine osmolality usually between 50 to 200. That is, if you have a diabetic insipidus, you will have very dilute urine. Your specific gravity will be 0.001. Maybe just dilute urine is passed and you will check the urine osmolality. That is very low, means 50 to 200. The plasma osmolality is more than 300. But urine osmolality, what happened normally is the plasma osmolality is maintained at 285 to 295. And if there is some dehydration or water intake is not normal and hot weather, your serum osmolality is maintained by around 285 to 295. It does not go to 295 because kidney try to conserve water. So urine osmolality would increase gradually to in response to low water in the body reserve. So in diabetes insipidus, your urine osmolality would be very low. Just you will pass urine and serum osmolality going high and high, maybe 300, 320, 310, because kidneys are just pouring urine. So then we have to make test to differentiate is it nephrogenic diabetes insipidus or it is a central diabetes insipidus. So first is the urine will be fast, very dilute urine, patient have polyuria, dilute urine, and plasma osmolality would be high. And low urine specific gravity if less than 0.005, it will be very dilute urine. So another in diabetes insipidus, you will see there is a raised in urea creatinine ratio, increased creatinine and blood urea nitrogen resulting from dehydration. So patient will dehydrated and you will have high urea creatinine, that is you're going to have a acute like patient in summer season they have severe diarrhea and they have vomiting and they are water dehydrated and water loss from the GI tract that leads to renal failure. Acute kidney injury means that your urea creatinine start rising because of the water loss from the GI tract and leading to dehydration and renal failure. As in positive, if you make diagnosis, then you go for water deprivation test. We'll discuss in detail what is the water deprivation test. So this is a normal what happens in diabetes insipidus is if you look at the plasma osmolality, you will see the plasma osmolality is high as compared to urine osmolality. The urine is just dilute urine and plasma osmolality is high. Patient is conscious and you can have a first mechanism stimulants can take place leading to polydipsia, fluid ingestion and fluid ingestion requirement may be decreased. But patient is unconscious, fluid ingestion can be reduced and you see there is a hypernatremia and dehydration. So this is a normal what happens in diabetes insipidus. Basically you will see raised plus serum osmolality, low urine osmolality, and you will make a water deprivation test. Okay, so after suspecting the disease, taking history and clinical examination, they may be dehydrated and you ask for investigation. So what are the symptoms? Patient may have change in mentation. If patient is severely dehydrated, may have hypernatremia. And patient may have insomnia, excessive thirst, polyuria, weight loss, and urinary frequency in polyuria usually 3 to 18 liters, 4 to 18 liters per day. Patient may have nocturia, is going toilet every 2 hours, and skin mucous membrane are cool, maybe wrinkles over the skin. The signs of dehydration can be there. Low urine osmolality because urine is just passed without any concentration. Low urine specific gravity and high plasma osmolality. This is a very important. And after 8 hours water deprivation test, you will see the plasma osmolality will increase and urine is still pouring out. That is one of the diagnostic tests of uh, water deprivation test. So diagnostic, clinical correlation, and the serum osmolality. So plasma ADH levels are tested just to see if it is it ADH deficiency or it is a nephrogenic diabetes insipidus. So so water deprivation test is very one should do very carefully because once you deprive the restrict the water intake and patient may be hypovolemic and may have because kidneys are not considered to conduct kidneys, especially in patient with central diabetic insipidus when ADH is lost and patient will continue having the polyuria and will become dehydrated and patient may collapse because of hypovolemia, and you have to monitor their urine output, their vitals. So water deprivation test is dangerous because it can cause diabetes insipidus, reduced water volume, and circulatory collapse leading to shock state. So without diabetes insipidus, is a rapid decrease. If patient is normal, he will, when water restriction is there, is no patient is not allowed to take water, and what happens is normally the patient will start having concentrated urine because the urine volume will gradually reduce because the kidneys are responding to normal water restriction. With diabetic insipidus, what happens is there is a urine volume will be the same. There will be excessive no urine volume reduction. The patient will have polyuria and urine osmolality will be almost 100, will be low, high volume urine, low osmolality. Means this is the objective of water deprivation test. You make sure is it because of kidneys unable to respond when you're having normal response, and ADH test when you give ADH challenge test, that is the differentiate between the neurogenic and nephrogenic diabetes insipidus. That is the challenge test for ADH. You give uh, subcutaneous or intramuscular ADH and see the response of the kidneys. So in neurogenic or central diabetes insipidus, the kidney respond by concentrate because in pituitary onset or diabetes insipidus, central diabetes insipidus, ADH is deficient and kidney will respond. If you give ADH, they will respond the kidney. They will try to concentrate the urine. But in nephrogenic, we know it is a disease of the kidney itself. ADH is okay. So in if you give ADH in nephrogenic diabetes, because again you will see kidney cannot concentrate the urine. So it has a disease of the kidney itself. So water deprivation try to differentiate between psychogenic polydipsia and to make sure it is a diabetic insipidus because of the central neurogenic origin. Because if you restrict the water intake, you will see there is a gradual conservation. Normally gradual concentrated urine is fast, and if you give daily AVP to the patient, you will see the response. Okay, DDAVP, if it is a central ingredient aptly insipidus, pituitary failure, it will respond. The kidney will try to concentrate the urine. If you see there is a no response to ADH, that means your pituitary, sorry, your kidneys are not responding to ADH, means you have a water loss through the nephrogenic diabetes insipidus. That is the difference between central diabetes insipidus and nephrogenic diabetes insipidus. Okay, water deprivation, as I told you, is a very sensitive test, and it should be patient should be admitted and monitored in ICU. He should be catheterized. The urine output should be monitored. Uh, Blood pressure should be monitored because you want to restrict the water intake. So patient should be weight, because if you have a weight loss of more than 30% within 2 hours, 3 hours water deprivation, 8 hours test, but you will see the patient is deprived of water. And plasma and urine osmolality are measured because urine osmolality is measured every 4 hours, plasma osmolality every 2 hours. You see the change in osmolality of urine and plasma. Like patient is deprived of water, and you see there is a response of the kidney to water restriction. If kidneys does not respond to just keep on pouring urine, that means diabetic insipidus. And is it central diabetic insipidus or nephrogenic? Then you give ADH, vasopressin, and see the kidney response. If ADH, after giving ADH, your kidney conserve or try to concentrate, the urine osmolality start increasing. That means it was ADH deficiency. If in spite of ADH injection, kidney doesn't respond, that means it is not the ADH deficiency, it is a nephrogenic diabetes insipidus, which is because of the kidney disease. So, patient should be deprived of water under constant observation and monitor hourly urine and serum osmolality, urine output, and weight. And primary polydipsia, if urine concentration and serum osmolality remains no, primary polydipsia means that the patient taking excessive amount of water and he will have both low osmolality. But in nephrogenic diabetes periods, after DDAVP, the kidney will not conserve because it is a kidney disease. If it is a central diabetes insipidus, after DDAVP or vasopressin, the kidney will conserve water. So this is a very important test to see water deprivation. Okay, if fluid deprivation does not result in urine concentration in osmolality more than 300, and body weight decreases by 5% of plasma osmolality rise above upper limit normal. Patient has severe pituitary or severe diabetes insipidus. So means your plasma osmolality start rising, your urine osmolality is still low. That means the patient is having diabetes insipidus, whether it is a pituitary or nephrogenic. The disorder usually can be distinguished by administering desmopressin, that is given subcutaneous or IV, and repeating the measure of urine and plasma osmolality. An increase of more than 50% indicates severe pituitary disease. That means if you give DDAP or desmopressin, the kidney responds. Means kidney is okay. It is the deficiency of ADH because of the pituitary or hypothalamic disease that has caused diabetes insipidus. And whereas a smaller or absent response suggests it is a nephrogenic diabetes insipidus, means after giving DDAVP, if kidney still does not respond, does not conserve water, and urine osmolality is still low, kidneys are just pouring water, that means DDAVP is given, kidneys are not responding. So this is called nephrogenic diabetes. So water deprivation test number one to differentiate, is it normal conservation and plasma and serum osmolality. Conservation of the kidney, normal kidney response. If there is rise in the urine osmolality, plasma osmolality, and urine osmolality remains low, means it is a diabetes insipidus. Now you give the DDAVP to differentiate, is it deficiency of DDAVP or ineffectiveness of DDAVP to the kidneys. So deficiency of DDAVP, after giving desmopressin subcutaneous IV, we will see the rise in urine osmolality, means the kidney will conserve water, the urine osmolality will increase, means kidneys are responding to desmopressin. In nephrogenic diabetes insipidus, the kidneys will not respond because it is a kidney disease itself, and there will be an increase in the plasma osmolality, but you will have the no effect in on giving desmopressin. So that is the nephrogenic diabetes insipidus. So plasma urine ADH, you can measure the ADH level, urine or plasma samples that collected at baseline, and falling water deprivation should be sent for the measurement ADH. Okay, you can check the ADH level. If there is an increase in plasma urine ADH in response to the rising plasma osmolality, then means there is a center diabetes insipidus excluded, means the ADH is rising. Rising means through negative feedback. If water restriction is there, ADH is rising means your pituitary axis is normal. If there is an inappropriate elevation in the urine osmolality as ADH secretion is increased, that means it is a nephrogenic is excluded, means the ADH is increased, and your osmolality, urine osmolality has increased. So diabetes, nephrogenic diabetic insipidus, when kidneys are not responding, and central diabetes insipidus, then there is a deficiency of ADH. You can see the pituitary area by going for MRI. This is very significant test. It, number one, you can go for water deprivation test. Number two, you can measure the ADH levels, and you can go for MRI of the pituitary and hypothalamus. In most healthy adults and children, posterior pituitary emits a hyper intense signals in T1 weighted mid-sagittal images. This is a very sensitive and important test to know, is it central diabetes insipidus, is it disease of the pituitary or hypothalamus. So when you do a T-weighted MRI, you will see a bright spot is almost always present in patient with primary polydipsia, means that is a normal, but it is invariably absent or abnormal small in patient with pituitary diabetes. When there is a pituitary damage, this bright spot is lost. So it is really also small absent in Naturogenic Diabetes insipidus because of the high secretion and turnover AVP. So if you look at the MRI, this bright spot is you can see normally a bright spot is there. This is a normal. This is a normal pituitary MRI image of T2, and this is the patient with diabetes insipidus. The central region, you see there is a loss of this bright spot. That is mean there is a central diabetes insipidus. So this is the normal with bright spot. This is the normal hypothalamic pituitary area, and this is the abnormal hypothalamic pituitary area, loss of bright spot. We'll go again the MRI test. The bright spot is almost always present in normal patient or primary polydipsia, but it is really lost, absent in patient with the pituitary onset diabetes insipidus. So pituitary loss is there because of this is a loss of this red bright spot in diabetes insipidus pituitary central in origin. So T-weighted MRI is a very sensitive test to localize the pituitary area, and we can see the loss of this normally, and this is the normal bright spot. This is the loss of bright spot, means there is a pituitary disease leading to cranial or central diabetic insipidus. Okay, so after water deprivation test, you see the response to ADH. If after giving ADH, kidneys try to conserve, that means kidneys are okay, and it is a deficiency of ADH because of the pituitary hyperthalamic disease. Then you can go for MRI to see the loss of bright spot after T2 image. In nephrogenic diabetes insipidus, after DDAP, you will see there is a no effect of kidney response. The kidney will not respond to injection of ADH and will keep on passing dilute urine with low specific. So that is nephrogenic diabetes insipidus. What are the treatments? Treatment depends on the cause and severity of the disorder. If you have a diabetes with a central in region, there is a deficiency of ADH, and the patient age, endocrine, and other cardiovascular status and lifestyle should be looked in before patient is put on ADH replacement therapy, because your pituitary damage is there, ADH is not sufficiently produced, and you have a polyuria. If patient is symptomatic and they have a large amount of urine, they pass up to 7 to 8 liters of urine, up to 9 to liter urine, or urine osmolality is less than 100, they are ADH replacement, and patient are given DDAP either intranasal or drops. That is comes in the DDABP is a name of drops which is available in market. They are given intranasal 4 to 5 drops per day, and they are absorbed. And intranasal, why we prefer intranasal DDAP replacement? Because DDAP blood pressure, there is no effect on the smooth muscle, and there is no change in blood pressure, because if you give intravenous or subcutaneous, it will have a drastic effect on the vasopressor response. So the patient may have hypertension and may have arrhythmia. If so, internal sphere has an advantage. It has no effect on smooth muscle, doesn't rise blood pressure, less likely to cause arrhythmias. And the patient should be monitored for the fluid overload and hyponatremia, because if you excessively DH is in place, patient will have conservative effect on the kidney, and kidney will try to conserve water, and patient may go into hypervolemic state. Hypervolemic patient may be water overloaded. When there is a water overloaded, they can have dilutional hyponatremia, and patient can have features of hyponatremia like agitation, confusion, disorientation, or even if sodium is low, less than 120, they can have fits, and so it is because of the brain edema. So DDAB replacement should be very very careful and usually given it intranasal because of its superiority effect on the blood pressure and arrhythmia, and especially you monitor the volume load. Chlorpropamide is another drug which can be used to try to suppress the thirst. Carbamazepine has a similar effect to chlorpropamide, and dapamide has a like diuretic, thiazide diuretic effect. It will reduce the water loss from the kidneys. And IM Peterson or Pituitrin bovine extract have been used, and they have a less effect. And IV vasopressin in emergency situation, if you have a patient in diabetes, he is hypovolemic, he is dehydrated, and patient is in a shock state, and patient collapsed because of hypovolemia, and resuscitation is done by giving IV fluids, and patient is giving IV desmopressin just to have a normal kidney conservation and with a fluid replacement. Nephrogenic Insipidus, kidney do not respond to ADH, means there is a kidney disease, and we don't have any pharmacological preparation of hormone. Basically, patients are given a low salt diet and may respond to some kind of diuretics because they increase the sodium excretion and by the kidney. So they reduce GFR, reabsorption of water in the proximal tubule is increased rather than collecting ducts. So as a diuretic, they improve the water reabsorption from the proximal convoluted tubule rather than the collecting ducts which are under influence of the ADH. Incomplete ADH deficiency can maintain normal or near normal water balance when permitted to drink water in small doses. So drugs that potentiate action of insufficient amounts of ADH, that is chlorpromazine and thiazide, can be added on with ADH replacement therapy. So basically, what are the treatment goals in patient with the diabetes insipidus is identify the disease itself and begin treatment early, because these are the patients who can have severe polyuria, polydipsia, they can be water depleted, and patient will go into hypovolemic crisis. So underlying the cause, whether it is a pituitary onset or it is a nephrogenic or kidney disease itself. The balanced fluid intake with output. So acute phase, rapid fluid replacement when patient is in crisis. Chronic phase, slow fluid replacement, and to prevent the cerebral edema. Replacement of ADH, as I told you, in emergency situation, it can be given IV, subcutaneous, or usually in patient in a emergency state when there is a hypovolemic patient dehydrated with volume replacement to give IV of supplementary ADH. DDAP intranasal is much better because of the smooth muscle effect, blood pressure response, and arrhythmia. They are less and they are usually given as a patient who are normally on treatment. Medication to stimulate production of ADH and reduce symptoms. They can have aggravating process. Weight gains, accurate in and output charts, gravity, and osmolality should be monitored in these patients once they are on treatment therapy. And objective is to maintain normal weight. They improve output balance. Their urine specificity and osmolality should be normally maintained. And age and culture, socioeconomic condition, they are very very important. And so treatment depending on the type of diabetes fetus, synthetic hormone called desmopressin, establishing the certain amount of water intake, low salt diet, and diuretic if decreased urine production in people with diabetes insipidus is required. Thank you very much. I hope you will go and go to your book and read the topic, and wish you all the best. Stay home and stay safe. Okay, Allah Hafiz. Thank you very much.